Medurstand. Understanding medicine.
I am Professor Aziz-ur-Rehman, and today we are going to talk about this condition called gastroesophageal reflux disease. It is actually another variant of a spectrum of disorders called acid peptic diseases. And the short is GERD, G-E-R-D, GERD, or GERD. People pronounce it differently. We call it GERD. So what is it and how do we diagnose? What are the treatment options? We are going to discuss in this relatively short video. So what is GERD? It is actually, I think, mostly a symptom. Mostly GERD can be diagnosed on just the symptoms if you listen to the patient, and patient will tell you what exactly is the problem. It is feeling of acid coming up in the esophagus due to incompetent or malfunction of lower esophageal sphincter. Now this is the anatomy, and if this is the esophagus and this is the sphincter, the lower sphincter, which must always close after we have eaten food, stomach will contract, but it will not allow any food contents or acid to regurgitate back into the esophagus. Occasional regurgitation is possible, but mostly the food contents will return back into the stomach if there is competent valve. But in those patients who have this valve with little lax, which is incompetent, there are various reasons why that can happen. But if this sphincter doesn't work properly, when you have eaten, especially when you have taken a full stomach meal, and then when your stomach contracts, some of the acid and some of the food contents can go back into the esophagus, sometimes right up to the pharynx, and it could actually regurgitate back into the trachea also. So this typically happens when you have taken a full stomach meal, and especially when you lie flat, and only in those patients who have malfunction of this valve. This is the normal anatomy and normal physiology, and why this does not occur, although mostly gastric contents, they stay within the stomach, acid and the food, they stay in the esophagus, although occasional reflux is normal, that is possible. Why it does not happen? Because this is the esophagus, and you see these muscles. This is the lower esophageal sphincter, which is an autonomically controlled sphincter, and it is reinforced by this diaphragm. Now, what are those factors which are likely to push your stomach contents into the esophagus? It's whenever there is increased pressure in the abdomen. So increased abdominal pressure will actually lead to reflex contraction of this sphincter, but at the same time, whenever there is increased abdominal pressure, that actually happens because of the contraction of the diaphragm. When diaphragm contracts, it moves downward, only then there is increased abdominal pressure. So whenever there is closure of the sphincter, that is reinforced by this diaphragmatic sphincter. So that is why in a normal healthy person, even if you have taken a hefty meal and even if you lie flat after the meal, usually there is no reflux. But occasionally this can happen. If these two are not at the same level, which I'm going to show you in some slides, because that happens in hiatus hernia, then this sphincter will not be supported by the diaphragmatic sphincter, and any increased pressure in the abdomen could actually overcome this resistance and then could regurgitate. So only when frequent and troublesome refluxes are present, then we call it GERD. So in a normal person, even if some stomach contents regurgitates into the esophagus, very quickly it is washed back into the stomach, and because of the contraction of the esophagus, peristalsis, and this is washed with mucus and the saliva, and then it goes back into the stomach. In those patients who have abnormal reflux, this acid content will stay in the esophagus for much longer, maybe all the time, and will lead to inflammation, erosion, ulceration, stricture formation, and other complications. So what are the causes? I think the most important cause is obesity, especially truncal obesity. Simple reason, when there is obesity, there is increased abdominal pressure, and also there is some anatomical change in the diaphragm and the esophagus. So that leads to reflux. Hiatus hernia, which is usually a congenital abnormality in the esophagogastric junction, and there are 2 or 3 types I'm going to show you in the pictures. So that is very important cause of reflux. Then previous surgeries on the stomach or in the esophagus or in the chest could lead to malfunction of the lower esophageal sphincter and can lead to reflux. And in many cases we just can't tell, maybe because there is no detectable cause or patient has not undergone the required investigation, so we can't really tell why this patient is having reflux. So in all the patients the symptoms are the same, the underlying cause may be different. So when we treat symptom, it may not matter what is the cause, but when the symptoms are very, very troublesome and when the symptoms cannot be relieved with routine therapy, then we of course have to investigate these patients and find out what is the cause so that the cause can be addressed and a more definitive treatment can be offered. So symptoms, first of all, the acid reflux, patient will typically tell that the highly acidic or sour fluid comes into the esophagus and sometimes into the mouth, what we call water brash. So patient may have typical symptoms of reflux and water brash, so that is important. Sometimes food might also come right up to the mouth. And then heartburn. Heartburn is like burning of acidic feeling or burning in this retrosternal region. Why do we call it heartburn? Because retrosternal pain is typically associated with the heart condition. So I believe that is the reason we call it heartburn. Although gastroesophageal reflux is nothing to do with the heart condition, except that it comes in the differential diagnosis. So retrosternal burning could be the symptom, and dysphagia, prolonged GERD can lead to sphincter formation and can be a cause of dysphagia. And sometime another esophageal disease which causes dysphagia may also lead to gastroesophageal reflux, like achalasia of esophagus. Then cough. This is very interesting. There are people who have these symptoms and there are people who do not have these symptoms, but they just have nocturnal cough. So I think this is very interesting because normally when somebody complains of cough, we think of a respiratory condition, maybe an allergic disorder. But remember, if somebody does not have other respiratory symptoms, or despite investigation you have not found any respiratory disease, do consider the possibility of reflux. And there are 2 important conditions which can cause this kind of cough, very interesting conditions to diagnose. One is reflux, the other one is a cough induced by ACE inhibitors. So when there are no other symptoms related to lung, no dyspnea, no expectoration, but patients have this nocturnal cough or daytime cough, I think that is very, very important clue to the diagnosis of esophageal reflux. Then hoarseness, because larynx is very delicate. Sometimes acid can go up to the pharynx and then enter the trachea and can irritate vocal cords, and patient may have this unexplained hoarseness. So if somebody has cough and hoarseness, these patients should be investigated for, of course, respiratory disorder, but also for gastroesophageal reflux. And there are many other conditions which we can associate with this reflux, like many dental condition, gum diseases, and sinuses disorder. Even some ear-related problems can be attributed to chronic reflux. So many times patients with reflux, they go to actually ENT specialists, and when they cannot find anything in the ear, nose and throat, they refer these patients to physician or gastroenterologist, and then we investigate them further and we find that they actually have this gastroesophageal reflux disease. Signs: in most patients there are no signs unless patient has developed some complication, and because of chronic dysphagia patient has lost some weight, or there may be occasional hematemesis because of the underlying cause, but mostly there are no signs. Physical examination will be usually normal. So how do we diagnose? I think I'm going to discuss the diagnostic approach. We have already discussed the typical symptoms, and I've already mentioned that there are no signs. So based on symptom, we make initial evaluation and then we go further. So if according to the initial evaluation, which is basically a detailed history, and if there are no red flag symptoms, patient has not lost weight and the symptoms are temporary, come and go, and patient does not have any hematemesis or there is no mass palpable in the abdomen, so I think then we go conservatively and we just try lifestyle changes, and I'm going to discuss in more detail what are lifestyle changes. And we also gave PPI trial, proton pump inhibitors, because proton pump inhibitors are very effective in lowering gastric acidity. So we try it for say 2 weeks and 3 weeks, and if there is complete relief, that would confirm the diagnosis of gastroesophageal reflux. Of course, you have to be sure that this is not a purely placebo effect. If patient is surely better with PPI and maybe with antacids also, then the diagnosis of gastroesophageal reflux disease can be confirmed, and then patient may be advised to continue lifestyle changes but use PPIs as and when needed. Continuous use of PPI is not recommended, so patient can take only when lifestyle changes do not control the symptom. But if this PPI trial does not lead to any improvement, then of course this patient would require further tests. Then because there may be some underlying disease which requires further investigation and treatment. And if there are red flag symptoms, one red flag symptom may be troublesome symptoms. There is nothing like suggestive of malignancy, but patient is really troubled. Patient is unable to sleep without any interruption, or patient has very, very troublesome symptoms. I think that is one reason to investigate. Otherwise, if patient has got hematemesis, patient has got weight loss, and then patient definitely needs to be investigated further. And these are 4 investigations which we can do. Endoscopy is probably the investigation of choice because you can actually directly see the condition of esophagus, and you can see esophago-gastric junction, and you can see if there is any further complication. So I think endoscopy is perhaps the best. And then conventionally we used to do this barium meal study. It is still done. So the basic principle is, this is basically to diagnose hiatus hernia. Patient is given a barium, patient swallows it, and then you take an X-ray, and if there is, and you can tell, especially if you take the X-ray in Trendelenburg position with head down, and in a normal person, once barium is in the stomach, it should not go back. But if somebody has hiatus hernia, you can see some barium above the diaphragm, so that will lead to the diagnosis of hiatus hernia. There are 2 types which I'm going to show you later. Then pH monitoring. The scientists say, the specialists say that pH monitoring is the definitive sign of reflux. I think philosophically, yes, because there are people who have typical symptom but endoscopy may be normal. Yes, you heard it right. There are people, I think maybe about 50% patient who have these reflux symptoms, but endoscopy is normal. That simply means that this reflux has not caused any further complication. But pH monitoring is actually measurement of pH in the esophagus. So whenever acid regurgitates back into the esophagus, there would be drop in pH. You know, low pH is acidic, so there would be drop in pH, and if you can document that, that would confirm the diagnosis of gastroesophageal reflux. Then similarly, gastroesophageal manometry, pressure changes in the esophagus is also important, and these 2 investigations are not routinely available in our country, so we mostly go by history and endoscopy. Now, these are types of hernia. I told you, other than obesity, one important cause of gastroesophageal reflux is hiatus hernia. Hiatus is actually this foramen in the diaphragm through which esophagus passes. So this is the normal person, this is stomach, and this is gastroesophageal sphincter, and this is the diaphragm. So stomach along with small part of the esophagus is actually below the diaphragm, right? And esophagus is, rest of the esophagus is in the chest. So this is a normal. And in this I told you, when stomach contracts, and this sphincter will contract, and it will be reinforced by the simultaneous contraction of the diaphragm, and food would not go back. Now this is a case of hiatus hernia called sliding. Sliding is as if the stomach is sliding into the chest, and this is part of the stomach which has gone above diaphragm. So since some part of the stomach is always above diaphragm, so some acid is always above diaphragm, practically speaking, in the esophagus, so it will easily go back into the esophagus and up, and this would cause a typical reflux symptom, and this is called hiatus hernia. And I think it is easy to imagine this condition as like short, relatively short esophagus. When we do endoscopy, we often mention that cardia, this is found at so many centimeters from the incisors. Incisors are a fixed anatomical landmark, and endoscope, we measure how far is this esophagogastric junction from the incisor. Normally it is about 40 centimeters. So in people with sliding hernia, this would be less. Of course, this 40 centimeters is not fixed, it would vary according to one's height. Then this is called paraesophageal hernia in this case, and there is actually a pouch-like structure parallel to the esophagus. So this is stomach in the chest. This may not be responsible for reflux, but this is actually, I think, more symptomatic, and this would also require some kind of treatment. Mostly, if this is causing symptom, maybe this would probably require surgery straight away, and this only is refractory cases. Now, let me show you the endoscopic pictures. The most important investigation is the endoscopy. Now, this is the sliding hernia. Now, you are looking into the stomach from the esophagus. The endoscope is higher up here, and this is the junction, and this is called Z line. And this, since this is columnar, this is squamous, they have different in colors. You can tell that this line differentiates between stomach lining and the esophageal lining. So this is actually the anatomical mark of sphincter, lower esophageal sphincter, this one. Whereas diaphragm is much lower here. So diaphragm is and the Z line are at a different level. So this means this is actually part of the stomach which is already above diaphragm. So esophagus is relatively small, Z line has moved upward, and part of the stomach is already present in the chest, and the diaphragmatic sphincter is much below. So this is sliding hernia, and in paraesophageal hernia, this is the endoscope, and it is actually retroflex like this, and this is the esophagus. Endoscope is coming out into the stomach and then is turning, and you can't see this part because this is taking the image, and you see this is the esophagus, and this is a pouch-like thing, a big pouch-like thing going into the chest. So this is paraesophageal hiatus hernia. There may be actually people who have a bit of both. Again, endoscopic finding you can see, and this is the scope, this is the Z line, and this is the part of the stomach in the chest, and this is actually the diaphragmatic sphincter. Here again, this is the scope coming. This is this coming from the esophagus, and then come here like it is retroflexed, and you see a big part of the stomach in the chest, and this actually this line coincide with the diaphragmatic diaphragm. So I think you can visualize this as part of the stomach in the thorax already. So these are two endoscopic finding of sliding hernia. Now, one reason why we worry so much about this gastroesophageal reflux is that it can cause what is called Barrett's esophagus. Barrett's esophagus can be easily identified by upward movement of Z line. This is a columnar metaplasia of esophagus. Normally esophagus is lined by squamous cells, but stomach is lined by columnar cells. If the gastric mucosa goes into the esophagus, and that would change the look of this mucosa, and this Z line would move upward. This is called Barrett's esophagus. This will be considered a confirmatory endoscopic finding, but it will also indicate the possibility of malignancy in future, because the Barrett's esophagus is considered to be a pre-malignant condition. And you can see in this picture, and there's a small nodule which is seen here in the magnified view. So this is actually an indication of maybe adenocarcinoma. This would definitely be biopsied, and this might turn out to be malignant. Now this is the Z line you can clearly appreciate, and this is also the Z line here. So Barrett's esophagus. Now after endoscopy, the second test which we can do, which we used to do more often in the past days, and that is barium studies. Now this is the barium study, and you can say patient is given, because normally you can't see esophagus or the stomach on the normal X-ray. Patient is given barium to visualize his esophagus. This is esophagus, and this is barium that has gone into the stomach, and this corresponds to diaphragmatic contraction, this part, and this part of the stomach is already above the diaphragm, and this is hiatus hernia. So this should be gastroesophageal junction, this one. So this is gastroesophageal junction. Let me show you, sorry, this one. This is gastroesophageal junction. Why can't show you laser? Yeah, this is the gastroesophageal junction, this one, and this is diaphragm, and this is the part of the stomach which has gone into the esophagus. Another test of gastroesophageal reflux disease is this 24-hour esophageal pH monitoring. Now patient, a catheter, a wire kind of thing is passed into the esophagus through the nose without any anesthesia, and then like we pass NG, and this has got various points, various sensors on it, and normally acid should not go back into the esophagus and pH should remain alkaline. But if you have a reflux, this would go up, and these sensor will pick up the acidity, and this device will register. And after 24 hours, now this will be read by a computer and will tell you at what time the pH has dropped below a specific number. So that will be considered diagnostic. If pH monitoring does not show any acidic change in the esophagus, then the diagnosis of gastroesophageal reflux disease is seriously questioned. Then patient may have some other symptom, or patient may have just psychological problem. Now, when it comes to treatment, there are 3 treatment modalities. We always start with the lifestyle changes, but in many patients, medication may be needed. In some cases, even surgery may be needed. So in all patients, we start with the lifestyle changes. Let's now examine what are the lifestyle changes which can help these patients. Reduce food intake, because typically when you take a full stomach meal, that is what typically precipitates gastroesophageal reflux symptoms. So patients should be asked to instructed to take a relatively small size of meal, particularly the night meal. If patient is not overweight, patient has got normal weight, he or she may be instructed to take more frequent meals, but individual meal size should remain small. And food should be not very rich in oil and spice, because oil increases the time food stays in the stomach. If the food in the stomach stays for longer, there will be more period for reflux to occur, and spicy foods are more likely to give you symptom of acidity and heartburn. So these 2 foods, especially some foods, if patient has identified a specific food like chocolate and coffee and whatever food patient has identified, I think that should be avoided, especially at night. Increase time interval between last meal to bed. Now, many patients, because of long days and because of busy life, they take their meal and then immediately go to the bed. So this is actually not right from health point of view. So patients should be instructed to take early supper, and ideally there should be the interval of about 3 hours between last meal and the time to bed, and this time should be spent in upright position. Now, if patient watches TV, patient should be instructed to watch TV in sitting position, not in lying position. So I think 3 hours or more in upright position is going to help. Then raise head side. There are people who, despite all this, will continue to have symptoms, so they may be instructed to raise their head side of the bed, and that will also help to prevent gastroesophageal reflux disease. Then weight management. Of course, in many patients, it is the weight. Now, weight management, of course, this reduction in food size would also help, but many patients would require specific treatment of weight. I have a separate video on obesity, so you can refer to that if you want to learn more about weight management. But of course, first thing is lifestyle changes, reduce food intake and increase exercise. But this, of course, is going to take time to work, so you start with this one and you also start working on the weight. So these lifestyle changes, along with some medication in some cases, should help in mild cases. So lifestyle changes we have covered. Now let's take the medication. Medication could be if somebody has occasional symptoms, intermittent symptom, that patient can take medication on as and when needed basis. But those who have regular symptoms, they could take regular medication. So occasional use, antacids are, I think, still very useful drugs. What are antacids? They are actually alkalis. They come in syrup. A patient takes 1 or 2 tablespoons, and there are some antacids which have some special physical character that they, I think it's called alginate. They float on the stomach. They're lighter than stomach contents. They float on the stomach, so they're alkaline. And if patient regurgitate food contents into the esophagus, it will be the antacid which will go, not the acid. So it will actually it will act as a plug, but also will help. But if something has to regurgitate to the esophagus, it will be this antacid. So I think this can be used in those cases where the symptoms are not regular. But those patients who have regular symptomatology, they need regular use of proton pump inhibitors. You can of course use H2 blockers also, or the new agents called PCABs, the potassium competitive acid blockers. They are supposed to be more potent than PPI, but traditionally we use PPI. There are so many proton pump inhibitors, and any one of them can be used, usually in slightly higher doses. Like for acid peptic disease, we use 20 milligram of omeprazole. In gastroesophageal reflux disease, we use 40 milligram, or maybe it's higher, because you need to suppress acid production more completely in gastroesophageal reflux disease. And then PCABs as an adjuvant therapy or in place of PPI in refractory cases. Then prokinetics. These are the drugs like domperidone or sulfdoms. These are the drugs, metoclopramide or domperidone, levosulfide. These are the drugs which improve gastric motility and they promote gastric emptying into the duodenum. They are usually not the treatment of first choice. Most patients will actually respond to just PPI and use of antacid, but some patients would need additional prokinetics also, especially those patients who have this feeling of bloating and fullness and the feeling as if the stomach doesn't get emptied. they would need prokinetics in addition to PPIs or PCABs. So I think most patients would be controlled with these drugs. So depending upon patient symptoms, you could use them on the regular basis, but it is always good to, I think, try lifestyle changes as much as possible and use these drugs only when lifestyle changes alone do not work. Because long-term use of PPIs, there are some concerns, so I think intermittent use is best. So there may be some cases who are actually truly refractory. Despite using these agents, in addition to lifestyle changes, their symptoms may still be there, so they would of course need something more definitive than simple medication. So that brings us to this possibility of surgery. Of course, surgery is, everybody wants to avoid surgery, and to my understanding, the results of surgery in gastroesophageal reflux disease is not very clearly predictable. So I think only those cases who are refractory should undergo surgery, or those patients who have big hiatus or hiatus hernia, either sliding or paraesophageal. Now, of course, I will not go into the details of surgery because I don't know them myself, but this surgery is called fundoplication. And there are, I believe, various types of fundoplication. This is Nissen's fundoplication, this is Dor fundoplication, this is Toupet fundoplication, and these pictures should give you some idea what they mean. So they kind of make this wrap around the esophagus, and I think this should stop the regurgitation. This is like correcting the anatomical defect by this surgery. Of course, it is a palliative thing, so I believe this kind of surgery would be helpful in those patients who are refractory. And some cases might need the PPI despite having undergone the surgery. So gastroesophageal reflux disease may be really troublesome and can occasionally be serious if it leads to esophageal malignancy or stricture or dysphagia or respiratory disease. Mostly it is, I think, troublesome symptomology, but occasionally it would lead to some serious complication. So a good understanding of GERD is very important to diagnose and treat them properly and to rule out other possibilities. So this has been Professor Aziz-ur-Rehman from Medurstand. I hope you like this video, and please join my channel Medurstand. It features all the topics in internal medicine and it is free. It is going to be free for life. Please join today. I'm going to leave my URL in the description below. Thank you.